by asking you a question. Of all patients admitted to an ICU, patients from which area would be the sickest? First is operation room, second is medical wards, and third is emergency department. Option one, have a show of hands. As you know, surgeons there, surgeons are there, they might show their hands. Option two, medical wards. Okay, some hands. Option three, ED. Okay. Right, let's see what the answer is. I mean, unfortunately, I can't find any Indian data. This is a study from Australia where they saw duration of life-threatening antecedents prior to ICU admission. It was done in the Liverpool Hospital in New South Wales, Australia. They looked at data of 551 patients admitted to intensive care, 90 from medical ward, 239 from OR, and 222 from the ED. And they found that patients who went in from the medical ward, they were the sickest. They had the highest Apache score. Mortality was much higher. It was 47.6 in those patients who went from the wards, or 19.3, ED was 31.5. And the number of serious antecedents before ICU admission was much higher in patients who went from in the wards. So 62 had antecedents during the period of 8 to 48 hours before admission. 53 had both within 8 hours and also 48 hours. What were the common antecedents? Hypertension, tachycardia, tachypnea, sudden change in level of consciousness. I mean, it's nothing new, but these were commonly seen up to 48 hours in the ward. What do we conclude? Often we take for granted that patients in general medical wards need not be monitored very closely. We do morning round, we do evening rounds. Rest of the time the nurses see, taken for granted. By the time they become sick, you're either intubating or doing CPR, and then you're shifting to the ward. So there's another study from the UK which did a confidential inquiry into the quality of care before admission to intensive care. Slightly older, but I think it's still relevant for us. It's a prospective confidential inquiry on the basis of structured interviews and questionnaire. It was done in a large district general hospital and a teaching hospital. A cohort of 100 consecutive adult emergency admissions, 15 each center were looked at. They've used two external assessors, opinions on quality of care, recognition, investigation, monitoring, and management of abnormalities of ABC, and oxygen therapy and monitoring was obtained. Based on that, they divided the patients into three groups. Group one, about 20 patients. All the assessors, both the assessors agreed that they were well managed. Group two, 54 patients. Assessors agreed that they did not receive good management. They received suboptimal care. Group 3 had 26 patients. They had split opinion on how they were managed. The case mix and severity of illness defined by Apache were similar in both centers and the three groups. As you would expect, the second group, where the external assessor said suboptimal care, they had higher mortality, 48% as compared to the other two. Hospital mortality was higher in this group. Admission to intensive care was considered late in 69% of patients in the second group, and overall a minimum of 4.5% and a maximum of 41% of admissions to ICU was potentially avoidable. So the authors concluded that suboptimal care is likely due to failure of organization, lack of knowledge, failure to appreciate urgency, lack of supervision, and failure to seek advice. This was, their conclusion. So, moral of the story is general medical ward patients can be sicker. They can become sicker under our nose, and we might see them in the morning, we might see them in the evening, we might miss a lot of things that happen in between. And personally also, a lot of us know that is the experience, because it would be lovely if you have one doctor for each patient or one nurse for each patient, but an internist can't have that. You go to work in a smaller setup. You would have to run the OPD, you have to run the ICU, you have to run the wards. Obviously, you need better systems to look after our patients. So what is happening these days? What we monitor is, so-called vital signs. Very old, 1886. That's when the coin, the term was coined. Temperature, heart rate, and respiratory rate were called vital signs. Later in the 20th century, blood pressure also it got added. These days, level of consciousness is also included in the list in many hospitals. So how frequently are vital signs monitored? We have the so-called TPR sheet. There's a lot of sentimental value. People think these things cannot be changed. I was talking to somebody, said that it's a hospital TPR sheet. How can we change that? But remember that system was established at some point in time, and we started using it based on some thought. Usually, semi-ICU Q second hourly, every 2 hourly or every 1 hourly is when usually it's monitored. And talking about vital signs, if you have a monitor, well and good. You have continuous numbers coming, but then how frequently are the nurses seeing it? How frequently are the doctors seeing it? Is a big question. General bed, usually 4 hourly. No matter what the patient has, usually it's in outer bed. It's usually 4 hourly. In some wards, it may be lesser if you have less staff. Majority look at the TPR sheet only for temperature. How many of you look at it for respiratory rate and BP? Most people don't. I can see a few senior hands going up. Very often you see it. Temperature is what we look. Very often it's not. The values are not considered reliable for some reasons. So there was a growing need to find out which patients are at risk of becoming much sicker, which patients are at risk of going into ICU, who can have a cardiac arrest in the hospital. It was a growing need. So in Australia, they came up with the concept of medical emergency team. It was developed by an anesthetist, Dr. Ross, in the same hospital, of the study, which I mentioned at the beginning. They made a list of parameters, including cardiac arrest, for which a medical emergency team could be called in the hospital. Now, we should remember that, the hospitals in Australia, in UK, Singapore, they will not be like Indian hospital. Each hospital has their own system. So they might have less staff, they might have, very different system from what you have in CMC or what you have in our Vellore Medical College. So anyway, if they have a ward, general medical ward, for example, usually managed by the nurses. The doctors may be there, they may be in the clinic, but if something happens, let's say patient develop hypertension, what do we do? Then they have this concept of this MET, where based on certain parameters, they can call them, and the team arrived and they did whatever they can for the patient. So this is what they had: airway, if it's threatened, breathing, all respiratory arrests, respiratory rate less than 5, respiratory rate more than 36, all cardiac arrests, pulse rate less than 40, pulse rate more than 140, systolic PPO of less than 90, neurology, sudden fall in the level of consciousness, repeated or prolonged seizures, or if any patient you're seriously worried about who does not fit the above criteria. If the nurse thinks that, okay, this patient is sicker, they could then call the MET. So that is in Australia. In UK, many centers, lot of publications kept coming, lot of speeches on this, and every other hospital started having this early warning score, and there were so many early warning scores. Every hospital has its had its own early warning score. So there was a growing consensus as to have a unified one. There was a need for consensus as to, because staff kept changing from hospital to hospital. They went to another hospital, they had a new early warning score, and if they changed to another hospital, another place, they had to deal with another one. So they needed a consensus. So the the Royal College of Physicians came up with this new score, which is called National Early Warning Score, in the year 2012, and it was modified later in the year 2017, and it's called News 2. Based on some changes. So early warning score definition is, it's a tool used by hospital care team to recognize early signs of clinical deterioration in order to initiate early intervention and management, such as increasing nursing attention, informing the provider, or activating a rapid response or medical emergency team. So we do temperature, pulse, and heart rate, but can we have a unified one? That was the question, and they came up with this early warning score. So I'm going to speak about NEWS a little bit. NEWS is basically National Early Warning Score, is founded on the premise that early detection, timeliness, and competency of the clinical response is a triad that determines clinical outcome in the acutely ill. So these matter. We all know that, but for that to practically put in place as to how it can change outcomes, you need a score. That's why the NEWS was developed. So it has six components. First is respiration rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion, and finally temperature. As you see, it's actually quite simple. A nurse can do it. Somebody who's trained can do it. And when you sit in the OPD, you can, if you have an automated system, you can see in the computer as to how these parameters are and how the score is. So a score is allocated to each parameter, and the magnitude reflects how extremely the parameter varies from the norm, and the score is then aggregated. If the patient was on oxygen, you added extra 2 points. So this is a score sheet. The first part of it is one sheet, but I split it into a few parts. So you have the basic demographic data and date and all that in the top. Then you have respiratory rate. So the ABCD is basically according to the the resuscitation pathway. So A plus B. First you start with respiration. As you can see, so if you have a respiratory rate of 24, a score of 2 is given. If it's 28, then you give 3. If it's between 12 to 20, that means 0. Then you have saturation. In saturation, the News 2 update had two scales. Basically, somebody who is hypercapnic respiratory failure, COPD exacerbation, for him, you're not really expecting a saturation of 98 or 100. 88 to 92 is okay. So you have scale 1 and scale 2. So somebody who's, if he has a type 2 respiratory failure, then use a second scale. And if they don't have a hypercapnic failure, then use a first scale. Then finally, if the patient is on oxygen, then you give an extra 2 points. So that is A plus B. Then you have blood pressure. You take only the systolic blood pressure. If it's more than 220 or equal to 200 and 220, you give a score of 3. And if it's 100, 1 to 110, you give 1, 91 to 100, you give 2, and less than that, you give 3. Rest are all, you just give 0. Pulse, similarly, more 90 to 110 is 1, 111 to 130 is 2, more than 131 is equal to 3, and it's lower, you start giving scores of 1 and 3. And consciousness, patient is alert, you give 0, confusion, VPU, that is, responds only to verbal command, pain, and unresponsive, you give 3. Temperature also you give based on what it is, you either give 1, 3, 1 or 2. And finally, for every time you do a set of readings, you calculate a score. And based on the score, you decide how frequently the patient should be monitored. So based on these, you can have 4 levels of levels at which you will have a clinical alert. A low score, a new score of 1 to 4 would be a low score. A single red score, an extreme variation in 1. For example, everything is okay, but only the BP is low. Then you would give, you could have a single red score. It may be just 3, but that's another level. Then you have a medium score, new score of 5 or 6. That's a key threshold, indicative of probably something acute happening. And 5 is also at the level where you would think of sepsis. And you can have a high score, 7 or more. So based on this, let's say the patient is in the general medical ward, this new score is 0, but suddenly it becomes 4. What should the nurse do, or what should the doctor who's there do? So obviously he should escalate the level of care. So 1 to 4, it should be initially seen by a competent registered nurse. This is the UK parlance, which the RCP has developed, but it would be here maybe a senior sister. The junior sister is monitoring. You inform the senior sister who is much more experienced, and she should then decide what should be done. If it's single red score of 3, again it should be seen by a doctor, preferably maybe a PG registrar. Medium news score of 5 to 6. It should be seen by a clinician, again a PG registrar, or if there's an acute team and who have people who are much competent in managing these acute illnesses, they should be seeing. A high news score of 7 or more should be seen by the team, or if there's a critical care outreach team, they should see, and they should have critical care competencies. And usually such patients might require a transfer to ICU. So frequency of monitoring, 0, at least 12 hourly, usually between 8 to 12 hourly. Because patients are stable, the chance of they becoming sicker is much, much lesser. 1 to 4, you monitor at least 4 to 6 hourly. Or if the clinician feels that this patient should be monitored more, then it should be monitored more. 5 to 6, or a red score of 3, 1 hourly until a plan is made and documented. And if it's 7 or more, each patient should be continuously monitored. The concept of, as I said in Australia, they have this medical emergency team. In the US, they have these rapid response teams. In the UK, they have this critical care outreach teams. We have CART team, usually called only for cardiac arrest. Usually it's a bit late. Cardiac arrest, it's just for CPR, intubation, all that. But can we think of some way in which the patient can be seen much earlier? That's the whole idea. By the time you call CAR team, by the time you do CPR, it's a bit late. Usually, mortality is very high in such patients. So they have these. We don't have that, but it doesn't mean that this is great. But I was talking to Dr. JVP. He said in Australia, medical emergency team. So in the ward, you call the medical emergency team. So the team which is looking after them, they say, okay, medical emergency team anyway will look after. You don't have to do much. So there are adverse outcomes also in that. So we should be careful, with having such teams. I'll give an example of how it's calculated. Let's say a patient with fever for 1 month. He's got a fever of 103 and a respiratory rate of 22, saturation 100% on 2 liters of oxygen, BP is 170, heart rate of 92, GC is of 15. Just see these numbers. Okay, 103, 22, oxygen 170, 92, 15. Let's see how much the score will be. What's the respiratory rate? I said 24, isn't it? So that would be 2. He's got saturation of 100, but he's on oxygen. So that would be 2. That's 2 plus 2, 4. BP of 170. So that would be 2 again, 6. And pulse rate of, I think I said 102, isn't it? It's 1. So that would be 7. He's fully conscious and he's got temperature of, you need to convert it into 100. Let's say it's 1. Comes to about 8. So such patients, I think I calculated before, came 6, I think. 6, this patient needs hourly monitoring, and you have to consider sepsis in this patient. Now, I should note that news should not be seen alone. It should always be used alongside clinical judgment. It is not a replacement for that. So if you are being called for high news score, let's say you have in your ward, you have the system, you have to ask history, you have to examine the patient, and you have to make a clinical diagnosis and use news alongside. This is just a tool for us to go to the patient early. And it's not for patients less than 16 years. There are other scores such as PEWS and MEWS and so many other scores which are being used in patients who are less than 16 years. Pregnancy also, they have other scores. Spinal cord injury patients also news is not very reliable because they have this autonomic dysfunction. So the score is not very reliable. So you would not use news score in these patients. Now, News 2 is implemented across the National Health Services UK. Every hospital has it. It's used by the ambulance service. It's also used by GP clinics. Now, what are the advantages? I think it provides a framework for action. News of 5, the nurses will ask you to do something. News of 7, you can't keep somebody with a news score of 10 without giving a proper thought as to, in a general medical ward. You will have to escalate care. So it forces you to do something. It empowers nurses. Nurses know that, okay, high in news score means patient is much sicker. The doctor has to act, and you have to come and see, act, and you need to document. It also helps in prioritizing resource and manpower. You would not want to sick patients be kept in, wards which have much less staff. You would not want to keep patient with a very low score in semi-ICU or in HTU. It also helps in deciding location of care and makes communication easier. The moment somebody hears the number, they have already a picture. Okay, this patient is much sicker. So it helps in that aspect also. Now, how do we implement it? We need to decide on an action plan. Each hospital has to decide who will respond for a high score, who will respond for a very high score, what should be done. A protocol has to be made. The nurses have to be trained, and the doctors also have to be trained as to how this should be used. Now, evidence, unfortunately, because everybody started using it without much RCTs, there are even no pre and post studies. There are studies which have looked at the concept of medical emergency teams, but just studies on just a score alone, not many are there. This is one systematic review which looked at early warning system scores in the US. It was done for the Department of Veterans Affairs. Their conclusion was that current early warning system scores perform well for predicting cardiac arrest and death within 48 hours, but impact on health outcomes and utilization of resources remains uncertain. That was their conclusion. This is one study from Singapore. It's a retrospective cohort study. They looked at news records of all patients admitted to acute medical ward in a Singapore General Hospital between August 2015 and end of July 2017. And they looked at the outcome, deterioration that required transfer to intermediate care area, ICU, or death within 24 hours based on one vital sign set. What they found was that as the news score goes up, the outcome also went up, and they said, it predicts outcome at 48 hours, fairly good actually. So it's being used there, and they found that this tool is quite useful. This is another study from King's College UK, which is a retrospective study, single center study. They looked at 500 patients and who came to ED, and they found that news of 3 or more at ED triage has a sensitivity of 92.6% and a specificity of 77% to detect patients at risk for severe sepsis at ED triage. There's another study which compared news with QSOFA and SIRS. It's again a retrospective analysis done in Urban Tertiary Care Academic Center in the US. They looked at 130,595 adult visits to the ED, and they found that news was more accurate for triage detection of severe sepsis and septic shock and sepsis-related mortality when compared to QSOFA and SIRS. They compared news with 33 other early warning scores. As I said, many scores were in use. They compared news with 33 other. They found that news did the best. Ability to discriminate patients at risk of cardiac arrest, unanticipated intensive care admission, or death within 24 hours. They looked at 35,000 patients. News did better than all the other scores. In summary, we need to remember that general medical ward patients need closer monitoring because they're at high risk. They're a select population with sickness. You've decided to admit them there. They need closer monitoring. Early warning score will help in deciding intensity of care. standard of care in many other countries. Simple to implement. Unfortunately, it's supported mainly by observational studies. We don't have RCTs. Maybe we can do one. I'm sure it'll make a difference, especially in a smaller setup, in a secondary care setup, where you'll have very limited resources, limited number of doctors. If you put in a system to inform you when the score goes up or goes down, it'll make a big difference in the lives of patients. I'll stop here.
Thank you for finishing on time.
Thank you, sir.
Any questions? I think our hospital is trying to introduce a similar form for the cardiac arrest team to alert clinicians or the nurses to alert the CART team. We have an informal team like this in the surgical ICU, and we have stopped some admissions or delayed admissions from the ward also. But what you say is true, that they call and they don't appear. The junior doctors who are registrar calls us, we go see the patient and nobody appears to. They don't come to see the patient, so it can be a bit of a problem. But I think, as you said, the respiration is something which we don't monitor very closely, and whoever monitors and writes it also, we don't know whether they are doing it. They are trained to do that. I think the weakest link is that the person who's on the floor, the nurses and the junior doctors, and if they activate and alert the senior ones, I think it will work well.
Any other questions?
And there, did they just call the senior general medical doctor, or did they call the whatever news team or the emergency team? Whom did they call?
They usually had a protocol. So if the news score was 7, they called the cardiac arrest team. They called the team that included the general medical registrar, an ICU registrar, 2 junior doctors. One team of doctors immediately went if the score was 7 or more. But if the score, let's say a single score of 3, the first usually called a senior nurse, then the junior doctor. But moment it's 5, 6, 7, they call the whole team. Especially,
would it work in acute care medicine? I don't know whether for patients who are been set to go to the OPD trials, could it work there? I'm just trying to think where we could use the news in our system.
This concept is unlikely to work in India. With the scale of the number of beds we have, number of patients we have, the load, it's just not practical.
Work in a ward with all the doctors?
Ward in the UK hospital with 100 beds, 200 beds, it might work. But a place like CMC with the load we have, and even if we identify something, ICU never has beds. So it's not like we can shift patients to the ICU immediately. So it's not practical for us.
My opinion is that it might help us, give more intensive monitoring in the ward itself. I know we have, less beds in ICU and HTU, but within the ward, if we have a system where maybe a larger semi-ICU where much intensive monitoring happens, maybe, it'll be helpful. Yeah.
I think I differ slightly from Dr. Abhilash. Earlier, we used to say, get the patient down from the ward. Okay, and we found that a lot of patients are actually arrest before they come to the ward, they arrest soon after they come to the ICU. Now we actually go, the senior consultant who's on the floor goes to the ward, resuscitates and comes along with the patient. With that, we found that, we have less of complications when they come down. So I think, as he said, the staffing is less and the number of patients are more.
People have to respond. You make use of the bleep system. I don't think we have a rule that you can't use mobile phones. Do we have that? No. not to my knowledge. You can use in your thing as long as you don't use it for your own personal thing while doing ward work. We don't have a rule as of now that we can't use.
I think mobile phones are everybody is using, but I think the duty mobiles can't do anything more than making phone calls. So
I agree. I know.
we should. I don't think there is any rule to prevent, and there is as long as the patient doesn't have an intracardiac device, there is no harm in using these. They don't interfere with the functioning of any equipment.
Dr. Osi has a question.
I think it depends on not just the way of communicating. I think it should be the level of communication where you communicate. Now, sometimes it stops at the registrar level. The communication for a sick patient, in my opinion, should go at the highest level so that decision can be made quickly. First call, second call, third call. It takes time, and the communication should be at the level of communication is more important than how you communicate.
Yes, I agree with that. Yeah. Yes, sir.
Ronald, I think we should implement it in the general medical wards, and I don't think an RCT is needed to, because higher the score, it means that this patient is sick and somebody needs to use it. Like we have morning rounds, we have evening rounds. What happens in between? So a nurse is monitoring this simple, routinely collected parameters, and if the score is above a certain cutoff, it should be informed to the person on call. And maybe the sicker the patient, higher the person whom you care. You don't even need a separate MET team. Same, the ward consultant or a senior person can come and see the patient. The trial should be, does it really, not whether it predicts an adverse outcome, adverse event, it improves outcome, the routine monitoring versus systematic implementation of an early warning score, does it improve patient outcomes? But then a sick patient should be seen immediately. There's no need to do a study on that.
Exactly.
One more question. Do you think we need to have different cutoffs for the severity in our setting?
That's something debatable. I think we should make a plan of action based on how it works. We should do a feasibility study to see how it works, how often people are called. Then based on that, we should have our own cutoff. That should be decided by each hospital based on our own setting. So if you are implementing the hospital where you are, you should make your protocol as to who will respond for a lower score, for a higher score, who would respond, how sooner, how faster. All that has to be decided. It's a bit of a work, but I think once it's put in place, I think it works really well. My experience was that, I worked 1 year in the UK. I saw medical wards being managed just by 7 medical wards being managed by one, just one junior doctor on the weekend, 1 or 2 junior doctors. The nurses were happy if the score was much lesser, and the score went up systematically. They called the patient they called the people whom should be called, and we didn't come across sudden cardiac arrest in the ward at all. Like in the 1 year, I didn't see somebody he had a sudden cardiac. It didn't happen. Moment patient reached 120, 130, BP is falling, new score is going up. Immediately there was a team and something was done. Either it was decided, he's not for resuscitation. A lot of patients, they were put in a side room, or they were shifted to a HCU or an ICU. So it does help. I don't think it is undoable in India. I think it will, all the more because we have less resources. But we need to apply our mind and make a plan of action. Thank you.